Dear colleagues, we are delighted to welcome you to the Precision Nutrition Research Gaps and Opportunities workshop. My name is and I am a senior scientist and leader of the Nutrition and Genomics team at the Jan Mayer USDA Human Nutrition Research Center on Aging. I am joined by my two co-chairs.
Hello, my name is Elizabeth Parks, and I'm a professor of nutrition and exercise physiology at the University of Missouri in Columbia, Missouri.
Hi, my name is Bruce Wiley, and I'm a professor of health policy and management at the City University of New York School of Public Health.
These 2 days will be dedicated to cover a wide spectrum of themes related to precision nutrition, with emphasis on identifying gaps and opportunities in this field. The workshop is composed of 5 sections, and I am sure that each one of you will identify subjects of his or her own interest, and it will benefit from many fruitful and enriching discussions. The overall format of the meeting is that for each section, there are talks, and they will be that will be presented, and then a discussion. In session 1, we will discuss what is currently known on the use of precision nutrition as it relates to some major chronic diseases.
In section 2, Holly Nicastro from the NIH will review the goals for planning research in the area of nutrition for precision health. She'll provide an overview of how the precision health efforts fall under the NIH's All of Us research program. Then, in section 3, the topics will include a review of research methods that can be optimized for precision nutrition. There are many efforts already ongoing, such as studies of the microbiome. Thus, we've not included presentations on some of these already established areas. Rather, the goal of section 3 is to understand known contributors of inter-individual variability in response to diet. And we'll discuss how studies must be carefully designed to allow for robust data collection in precision nutrition.
Then on day 2 of the workshop, we will focus on how emerging technologies and approaches like artificial intelligence or AI, computer modeling, machine learning, and other types of data science can facilitate precision nutrition by helping us better understand and address the complex systems involved. There are plenty of opportunities, but also lots of pitfalls. So the 2 sections, sections 4 and 5 on day 2, will cover these, as well as how to train a new generation of scientists that can bridge nutrition and different computational approaches. Workshop registrants will learn about poster awards on day 2 of the conference. Awards will be given to posters deemed meritorious and related to precision nutrition. Only non-governmental employees, early-stage investigators, graduate students, and postdocs with meritorious posters and abstracts will be given awards. Please visit the poster hall and view or listen to the posters. Next, we'd like to introduce Dr. Griffin P. Rodgers, Director of the NIH's National Institute of Diabetes and Digestive and Kidney Diseases, and Gary H. Gibbons, Director of the National Heart, Lung, and Blood Institute, who will formally open the meeting.
Good morning. I'm Griffin Rodgers, Director of the National Institute of Diabetes, Digestive, and Kidney Diseases here at NIH, and I also co-chair the NIH Nutrition Research Task Force. I'm pleased to welcome you to the Precision Nutrition Research Gaps and Opportunity Workshop. I want to especially thank the co-chairs, world-class speakers, panelists, and poster presenters, along with the organizing committee for making this meeting possible. We look forward to hearing about your work and thoughts, not only about precision medicine, precision nutrition, but also its intersection with artificial intelligence and data science. The long recognized importance of nutrition for good health naturally leads to the practical question of what we should eat to stay healthy. However, the answer to this is complicated. Many studies have revealed profound differences between individuals and disease risk and biological responses to dietary interventions, making it challenging to fully answer this question. A strategy to address the issue necessitates moving beyond one-size-fits-all dietary prescription for optimal health and disease prevention. The modern view of food and medicine is leading to a substantial shift in nutrition research and practice towards precision nutrition, which has great potential to offer multidimensional and dynamic nutrition recommendations. Our primary goal of this field is to optimize metabolic responses in individuals or population subgroups through tailored dietary approaches, resulting in prevention and treatment of disease and improved overall health. Many factors affect individuals' physiologic responses to diet. Precision nutrition aims to understand the complex interplay among genetics, microbiome, disease, and drug exposures, metabolism, food environment, and physical activity, along with economic, social, and other behavioral characteristics. Only with a firm grasp of the relative contribution and interrelationship among these factors will it be possible to develop targeted nutrition guidance for diverse individuals across the population. Precision nutrition science enables individual dietary recommendations and therapies based on these factors. Now, there's burgeoning scientific and public interest in precision nutrition. Precision nutrition is increasingly featured in news and social media. There's also a growing awareness about the related field of precision medicine, along with increased consumer access to personalized health, genetic, and microbiome-related information. Finally, compared to other factors underlying health and disease, such as genes and environment, diet is something over which the public may have a relatively greater measure of control, driving further interest in this topic. Therefore, the NIH's leading efforts to advance precision nutrition as the best strategy to catalyze nutrition science and related fields in meaningful, clinically relevant dietary solutions for both individuals and groups. This is reflected in our NIH Common Fund investments in metabolomics and the Human Genome Microbiome Project, along with the recently announced Common Fund project, Nutrition for Precision Health, powered by All of Us research program. Now, you'll hear about more later today. Now, we look forward to hearing today and tomorrow about the exciting work being done in this area. And throughout the workshop, we would like to challenge our speakers and audience members to join in the discussions with your ideas for research opportunities to better understand precision nutrition and also the technological and computational tools which will be needed to bring this vision to fruition. Please think about these questions and share your ideas with us. I want to thank you for your participation, and we hope you enjoy the workshop on this exciting and important topic. Now I'd like to pass the virtual microphone for some additional opening remarks from my colleague and co-chair of the NIH Nutrition Research Task Force, Dr. Gary Gibbons, Director of the National Heart, Lung, and Blood Institute at NIH, who is co-sponsoring this workshop together with the NIDDK and the NIH Office of Disease Prevention. Gary.
Hello, I'm Dr. Gary Gibbons, Director of the National Heart, Lung, and Blood Institute, and I want to extend my welcome as a co-chair of the NIH Nutrition Research Task Force, alongside my partner, Dr. Rodgers. I want to extend a welcome to this precision nutrition workshop on research gaps and opportunities. And we're excited to have this privilege to join with you virtually as part of this meeting. We're encouraged about the enthusiasm exhibited in the fact that we have over 1,000 registrants for this virtual meeting. And we look forward to the discussions, deliberations, and ideas that will come forth as part of this meeting. As one of the co-chairs for the Nutrition Research Task Force alongside Dr. Rodgers, we really appreciate you leaning in and lending your expertise as we start to execute the strategic plan related to precision nutrition and seek opportunities, particularly to see the importance of nutrition in preventing disease. We recognized for many years the linkage between nutrition and diet and how they play a role in the trajectory and development and susceptibility of the leading causes of death, such as heart disease. We recognize the interplay between nutrition and the immune system, and increasing recognition that the immune system plays a key role in a variety of chronic disorders. Similarly, it's also increasingly clear that what we eat, when we eat, and our individual backgrounds are affected by our diet and the disease state trajectory that affects outcomes. So we recognize that precision nutrition enables us to understand these different variables and effects, the complex interplay between genetics, factors such as the microbiome, metabolism, the variation in the metabolome, as well as cultural factors, food selection, dietary habits, as well as environmental considerations, social determinants of access to certain foods and a healthy diet. This complex interplay from the DNA to our behavior all works together to influence the trajectory of health and disease, and nutrition and dietary patterns clearly play an important role. We recognize that there's a great opportunity to further precision nutrition research, and we look forward to this exciting two-day deep dive on the role of nutrition in chronic disease, with a further understanding of that inter-individual variability, as well as the influence and the trajectory of chronic disease. We see incredible opportunities that exist related to the promise of integrating new analytic tools of data science. And as always, a key part of our mission is to train the next generation. And we see precision nutrition as a very exciting new vista for young investigators to pursue. There are many important questions and challenges that need to be addressed that this workshop will address and assess as we implement the strategic plan for NIH nutrition research. Clearly, this topic is a key part of that strategic plan. From a perspective of the NHLBI, we see great opportunity to pursue important unanswered questions. The NHLBI is a decades-long legacy of investments in nutrition research that has given insights into the importance of dietary patterns in heart disease and the incidence and control of disorders like hypertension. And in particular, we see a great opportunity to influence women's health, particularly women in their reproductive years, in which we are concerned about the prevalence of maternal morbidity and mortality, particularly in high-risk health disparity communities, and a recognition that some of those factors of excessive weight gain, the complications of pregnancy, such as hypertension and diabetes, relate to dietary patterns. This suggests that we may have a great opportunity in precision nutrition to have interventions that could change the course of both preconception, pregnancy, and postpartum trajectories of health in these women. And we see potentially opportunity, for example, with our DASH diet, to change that trajectory. And so if precision nutrition can then guide more effective interventions, we think that would be a great outcome. So we look forward to this two-day workshop, and want to thank the staff and the organizers, the co-chairs, for putting together a great program, and we look forward to your contributions to it, and thank you for your participation.
Thank you, Dr. Rodgers and Dr. Gibbons. I'm delighted to introduce my fellow co-chair, Jose M. Ordovás, Ph.D., who will be leading our first section. He is a professor of nutrition and a senior scientist at the USDA Human Nutrition Research Center on Aging at Tufts University in Boston, Massachusetts, where he is also the director of the Nutrition and Genomics Laboratory. In addition, he is Professor of Genetics and Pharmacology at the School of Biomedical Sciences. Dr. Ordovás' primary research interests focus on the genetic and epigenetic factors predisposing to age-related chronic diseases, such as cardiovascular disease, obesity, and diabetes, and their interaction with environmental and behavioral factors with particular emphasis on diet. He has published over 850 scientific articles and written books related to precision nutrition. In this regard, he is considered a pioneer and one of the most distinguished world experts in gene-diet interactions pertaining to cardiometabolic traits. Throughout his career, Dr. Ordovás has received multiple honors for his scientific achievements, including the Secretary's Award from the USDA, the Centrum, the David Krzyzewski's Career Achievement, and Dannon Institute Mentorship Awards from the American Society for Nutrition. He has been awarded an honorary degree in medicine bestowed by the University of Cordoba in Spain. He is a member of the Royal Academies of Science, Medicine, Nutrition, and Pharmacy in Spain as well.
Thanks, Bruce, for your kind introduction. First of all, we want to express our gratitude to Dr. Rodgers and Dr. Gibbons for their support to nutrition research within the NIH and for spearheading the Nutrition for Precision Health Research Program. Thanks also to the NIH Organizing Committee for the workshop, especially to Christopher Lynch, Charlotte Pratt, and Holly Nicastro. Holly will be speaking in a couple of hours about the research program details. And I am sure everybody is looking forward to her lecture. A special thanks also to Kimberly Barge, who has been supporting and coordinating the development of the workshop. Finally, thanks to all the attendants for your interest and for being with us during these 2 days. During section 1, we will have a series of 4 pre-recorded talks, followed by live question and answer. So I encourage you to participate at that point with your questions. Then we will follow the discussion by a panel of experts. This session will focus on precision nutrition in relation to some major chronic diseases. The objective is to set the stage and serve as a trampoline towards the future. Therefore, we'll be presenting what has been accomplished in the field of precision nutrition, and that progress and the knowledge that has been generated will be crucial to identify those gaps and opportunities that we are looking in this workshop in terms of future actions. My talk will start as off, and I will be covering precision nutrition and cardiovascular disease. Then Richard Isaacson, director of the Alzheimer's Prevention Clinic Weill Cornell Memory Disorders Program, among several other positions, will talk about nutrition and cognitive function and Alzheimer's. Obviously, the decline of cognitive function and the appearance of Alzheimer's is a major problem in our society that is aging. Then it's obviously essential to identify the nutritional approaches that will keep that cognition function for longer, and it will delay the expression of the Alzheimer's disease. During the third talk, we will hear from Mary Ann Sevick about precision nutrition and type 2 diabetes and impaired glucose regulation, a huge and increasing problem in our society, but even more worrisome in terms of absolute numbers in developing countries. Mary is professor in the Departments of Population Health and Medicine at NYU. In the fourth and last talk of the section, Emily Ho, director of the Linus Pauling Institute at Oregon State University, will discuss precision nutrition in the context of primary and secondary prevention of cancer. Probably the disease whose mention raises more fear among people. Well, concluding her talk, we will go live again to entertain questions from the audience for about 10-15 minutes, followed by the panel of experts who will be discussing research gaps and opportunities around the topic of this section. On the panel is Linda Van Horn from the Northwestern University Freiburg School of Medicine, Corby Martin from the Pennington Biomedical Research Center, Steve Clinton from the Ohio State University, and Paul Frank from Lund University in Sweden. And the last panelist is Simin Meydani from the Jan Mayer USDA Human Nutrition Research Center. So now let's begin with the talks. Thank you very much.
Good morning. What I want to share with you in the next few minutes is the current status of precision nutrition and cardiovascular diseases. However, before getting into precision nutrition, let's just talk for a moment about nutrition. Last week, I was browsing the NHLBI website and I found this headline: NIH-supported DASH diet tops rankings for heart healthy and healthy eating. Obviously, I was curious. I went into more detail, and yes, there was the DASH diet for every category, sharing the podium with the Mediterranean diet in terms of the best diets. So here we are, two diets, similar. You can go more after one or another, depending on your culture and your taste and so on, but that could be the solution. So why do we need precision nutrition? The reason is because we are very complicated. And that complication shows here, because it doesn't matter if you want to lose weight and you use one diet or another, or reduce cholesterol levels, or triglycerides in the postprandial state, or glucose, or blood pressure. You always have a huge inter-individual variability as shown here. Let's stop for a moment here in terms of the blood pressure in the DASH sodium trial. And here we have the variability that we have mentioned. Seems like on average people decrease the blood pressure. And what was the diet change from 140 millimoles per day of sodium to 62 millimoles per day of sodium. Okay, let's now move to the right panel. And again, the same variability, but in this case, the diet didn't work very well. But still, you have people that lose blood pressure or decrease blood pressure, and some people that increase. What were the changes in the diet? None. It was the same diet. So that just shows you how what I mentioned before, that we are complicated. And we have been trying to solve this, some of these complications by looking for many years at gene-diet interactions. And that's what has been dominated the landscape in terms of cardiovascular risk factors and cardiovascular itself. Now, if we look at that landscape, most of the studies are observational, looking at cardiovascular risk factors in terms of interactions. There are less intervention studies, usually very small, and even less observational studies looking at CVD events, and even less to intervention studies and CVD. So we are going to see a couple of examples from the upper and the lower range. And this is a classical example. In this case, what we did was to look at a promoter polymorphism in the ApoE2 gene and saturated fat, and as an outcome was BMI. In the Framingham study, what we have is that people that were either TT or TCs, it didn't matter in terms of BMI, whether they were consuming a low or a high saturated fat diet. Now, if we move to the CC individuals, now there was a huge difference between consuming one diet or another, right? So a very significant gene-diet interaction. Now, if we move to the right, we find the results from Golden, which is a study that was carried out with people from the family heart study, also from NHLBI, in Minneapolis and in Salt Lake City. Same thing. What do they have these studies in common, besides the fact that they were NHLBI cohorts? The fact that they were whites. So we took a look to what happened in Hispanics in the Boston, Puerto Rican health study. Same thing. Then we moved west, outside of the US, and then we went to Europe, same thing, and we moved even more east, and in Singapore we found exactly the same thing. So very interesting, very happy about that. We have replication on 5 populations and 5 ethnicities, but are we ready to take this to the streets as a clinical application? The answer is no, because we are talking about observational studies. These are not intervention studies, and we cannot prove causality. Okay, so let's move on. And remember, the other studies were those that were looking at genes and the outcomes were cardiovascular events. Well, here we have the PREDIMED study over 7,000 people, and you can analyze this both ways, observational or intervention. If you look at the observational part at baseline, what you have is that this variant, that it happens to be functional and gain of function, and we reported that earlier, and the functionality depends of an binding site for a microRNA, then you expect that the CCs will have lower triglycerides because they have a higher lipoprotein lipase activity than the TTs, and that's what happened. Now, if we input the diet here, what you see is that there is no change for TTs, independent of the diet, but for CCs, yes. Now, a higher intake of unsaturated fatty acids means lower triglycerides. So you bring up the benefits of this polymorphism. Let's move now to the intervention side. Let's randomize to the intervention, and let's now see what happens after a few years. And then in the control group, remember, low-fat diet, nothing happens in terms of triglycerides. In the Mediterranean group, yes, we have a very nice gradient, similar to what we expected from the observation component of the study. So great, we have demonstrated that with an intervention, we can modify a cardiovascular risk factor, but can we modify the CVD events, the CVD risk itself? And in this case, what we look at the stroke, and in the control group, remember, no changes in triglycerides, no changes in incidence of a stroke in this group. If we look at the Mediterranean diet, changes in triglycerides, and that brought associated a significant difference between C carriers and TT when it came to incidence of stroke. So very important findings that demonstrate that with precision nutrition, you can modify risk factors, but also you can modify the endpoint, which is cardiovascular disease itself. Let's make things more interesting. Let's look at precision chrononutrition. Time matters. And it matters for cardiovascular disease because here we have, for example, what happened with circadian rhythm. People have more events in the morning than at any other time of the day. And also, if we look at seasonal variation, people die of cardiovascular disease more in the winter than in the summer, independently if you are in the northern or southern hemisphere. If you are in the equator, it doesn't matter. There are no seasons, so there is no variability. Is that common to all diseases? Well, cancer mortality, no effect whatsoever of the seasons. So let's look at an example of this chrononutrition. And here what we have is a study carried out by Marta Garolet, in which she put people into a intervention program to lose weight based on changes in diet and changes in behavior, and some people did it better than others. What was the difference between one group and another? Not what they were eating, but when they were eating. These people were eating later than these people. So what is the recommendation here? Well, let's just to have public health recommendations that people eat earlier. Well, not so simple. Let's bring the genes here. And in this case, there is pre-lipin-1 gene that is expressed in the adipose tissue. And this is the picture that we get. If you are a T carrier of this polymorphism, it doesn't matter if you eat early or you eat late in terms of your success to lose weight. Now, if you are an AA, that's a different picture, because now you have a lot of very good success if you eat earlier, and poor success if you eat later. So it's for these people that applies this recommendation of eating at one time or another. Now, another component of the circadian rhythm is sleep. We know, and we have demonstrated that in the PESA study, that there is a relation between sleeping and cardiovascular disease. So if you sleep, if you are a very short sleeper or a long sleeper, you have more cardiovascular disease than if you are an optimal sleeper. And the same applies to fragmentation of sleep. Now, let's see if we can play around with this. So first, some time ago, we identified SNPs in the clock gene that they were associated with BMI, they were associated with cardiometabolic risk, and maybe they were associated with cardiovascular disease, just maybe. So let's see if we bring the sleep here. And this is work that was carried out by Hassan Dasti. And what he found is that better sleep, healthier diet. And that healthier diet was able to quench the negative effects or adverse effects of the clock SNPs in terms of BMI. Now, we can assume that then that the impacts on metabolic risk and cardiovascular risk. But we did that. In a different study conducted by Dolores Corella, what we found is that diet was able to quench the adverse effects of these clock SNPs in terms of cardiometabolic risk, but more interesting in terms of cardiovascular disease itself when we look at the stroke. So this is an example of how we can integrate all these different factors, genes and diet, behavior in terms of sleep, and the chronobiology as a whole, in order to provide more precise nutrition. And with this, we get to the gaps and opportunities. There are many more than the ones listed here, but we don't have time to go through all of them, and we'll see them through the other lectures in this workshop. And first, most of the studies are observational studies, so we don't have proof of causality. We need better dietary assessment. We have very poor knowledge of the exposome. We don't know what is in our food. So, like now, we have this hypothesis that we don't know what is in 99% of the food that we eat. But even if we knew it, we don't know the effect of what it's going to have, what we eat, depending on how it's cooked, the matrix, and so on. There is a lack of ethnic diversity. We don't study biological sex properly. Most studies are based on CVD risk factors. We don't have a good integration of the different measurements. So we have plenty of opportunities. We need to develop objective and precise measures of dietary intake. We need to conduct intervention studies. We need better understanding of metabolomics and microbiome data. And we need real-time monitoring, and we are able to do this nowadays. Better data integration. And when we do that, then we are able to reveal mechanisms of things that we have been finding along these years, like the mechanism behind this interaction between ApoE2 and saturated fat intake. And we saw that it has an epigenetic mechanism that is then captured by the metabolomics and even could implicate the microbiome. We need to develop robust artificial intelligence, machine learning, and in the case of cardiovascular disease, we need to also bring to the studies subclinical measures for atherosclerosis. We cannot conduct intervention studies for decades to see if people develop or not cardiovascular disease. We need to take advantage of meal challenges and look at the postprandial state. We need to integrate chronobiology, and we need better knowledge of the foods that we eat and how they are processed. And I don't mean industrial processing, but in terms of what I said before, the cooking, for example. And then we'll be able to finish with this problem that we have nowadays, in which each investigator or each lab comes out with different answers. It's the genetics, the epigenetics, the smoking, the metabolomics, the microbiome, the diet, and so on. So, yes, soon we will be able to integrate all these measures. Then the landscape will not be entirely occupied by genetics. It will be shared by many other types of measures, like epigenetics, like the microbiome, the lifestyle, other diseases, and the chronobiology, and so on, and of course, the use of metabolomics. And then we will be able to integrate all this, and with the use of artificial intelligence, then we'll be able to serve the precision nutrition plate. When do we start cooking this precision nutrition plate? The time is now. We have all the ingredients, we just have to connect the dots, and obviously we need the funding in order to carry out the work. And with this, I want to conclude my presentation, and thank you very much for your attention. And now we are going to listen to Richard Isaacson to talk about precision nutrition, cognitive decline, and Alzheimer's. Thank you very much.
My name is Richard Isaacson. I'm a clinical neurologist and clinician researcher. I direct the Alzheimer's Prevention Clinic at Weill, Cornell Medicine, and New York Presbyterian. And I'm really excited to be here today. I'm very humbled and honored and appreciative of the invitation. Every day in my clinic, we apply emerging principles of precision nutrition for patients at risk for both cognitive decline and Alzheimer's dementia. It's just a real privilege to be able to be here with you today. So I want to first start out with my disclosures. I've received several grants, also one that's important, the NIH Clinical Research Loan Repayment Program. They paid back about a third of my student loans, so I appreciate that. Also several grants from philanthropic support. The work we do sometimes doesn't have some of the more established grant mechanisms, and for the last decade or more, I've really been dependent on the vision of philanthropy. I'm a trustee of the McKnight Brain Research Foundation that focuses on cognitive aging research. And I think in terms of disclosures or biases and why I think the way I do in terms of trying to intervene against cognitive decline and Alzheimer's early is because of my family history. My Uncle Bob and my dad's cousin Charlotte. This is a picture of my family. This is actually my cousin Erwin's bar mitzvah back in May of 1946 in Flatbush, Brooklyn. This is an important picture because 4 people in my family developed Alzheimer's disease. And I think what most people are unaware of is that Alzheimer's disease starts in the brain over 20 to 30 years before the first symptoms of Alzheimer's disease begin. And in my family, I saw this. So a lot of us think of Alzheimer's disease as an older person's disease, but I think a little differently. For example, if at age 85, 45% of people have Alzheimer's, well, in that person, the disease first started between their ages of 55 and 65, and that's more of a middle-aged disease. But if we take it even earlier, if at the age of 65, about 10% of people have Alzheimer's, well, that disease first started in their brains in the ages of 35 and 45. So again, this should be thought of, cognitive decline and dementia should be thought of as a younger person's disease and a middle-aged person's disease. And if we can do something targeted early before symptoms begin, that's when we can have the most successful chance for benefit. So we started back in 2013, the first Alzheimer's prevention clinic, to my knowledge, in the United States. And what we've tried to do is take people like me with a family history of Alzheimer's and other cognitive disorders, and we apply the best available evidence. We take an evidence-based but safe approach. And what we've really learned is that it's not a one-size-fits-all approach. It's honestly not an algorithm. There's no one perfect recipe. And we need to individualize care. And a major cornerstone of our care is along the lines of precision nutrition. When it comes to the evidence, there's just been so many randomized controlled trials, so many epidemiological studies, so many studies out there. And what we try to do is take this information and apply it in everyday clinical practice, from the finger study, which really changed our field quite a bit, to other studies. We really now have sufficient evidence, I believe, at least, to give some patients some guidance. When it comes to nutrition and Alzheimer's disease specifically, there's literally been an exponential growth of clinical trial evidence. I've been using this slide now for almost a decade. Back in 2010, when you searched Alzheimer's and diet in PubMed, you came up with 30 articles, 30. Now in 2021, we're at over 3,000 publications. And these are across the spectrum of Alzheimer's, also mild cognitive impairment due to Alzheimer's, which is the first earliest symptomatic phase of Alzheimer's disease before dementia. And then if you drill down even deeper, what we realize is that only 57 of these publications in 2021, only 57 include the terms precision nutrition. So we're about a decade behind in terms of our advances in precision nutrition, but we've made strides, many strides forward in the field of Alzheimer's disease and nutrition specifically. When it comes to nutritional interventions, I won't go into too detailed, but we think about these things in terms of dietary patterns. By far the most evidence for brain health is Mediterranean-style diet. But honestly, the single and multi-nutrient aspects are critical, from omega-3s to B-complex vitamins and so on and so on. When it comes to precision nutrition interventions for brain health, I think just to keep things more simple and as evidence-based as possible, ApoE, the ApoE genotype, basically mom and dad gives you a copy. You either get a copy of 2, 3, or 4 from mom and a 2, 3, or 4 from dad. And if mom or dad gives you 1 or more copies of the ApoE4 variant, that person has an increased risk of Alzheimer's. About 25% of the population has at least 1 copy of E4. The impact of nutritional interventions interventions differs based on the person's ApoE4 status. So if we think about precision nutrition in terms of personalized nutrition and genetics alone, then we can think about alcohol, for example. Maybe we need to tell people different instructions about alcohol and different guidelines based on how much one needs to drink or doesn't need to drink based on their Alzheimer's risk, and to try to intervene in a more precise fashion. Mediterranean style diet may tend to work better in some studies without the ApoE4 variant. B complex vitamins, for example, benfotiamine, a version of B1. Gary Gibson just published a paper showing that, you know what, depending on E4 status, the benfotiamine may or may not be effective. Same thing with omega-3s, vitamin D, medium chain triglycerides. The list goes on and on for the most common genetic risk factor for Alzheimer's disease. Now let's get a little bit more deeper, because, you know, when we talk about precision nutrition, in my mind anyway, we don't just think about genetics. We think about, well, what is that person's biology? What is that person's other aspects? Do they have enough B vitamins initially? Do they have an elevated level of homocysteine, for example? So there was a study, and really multiple studies by David Smith, really a pioneer in this field, looking at people with mild cognitive impairment. Again, that's pre-dementia, early symptomatic, for example, phases of Alzheimer's. And only those people with elevated homocysteine levels benefited from B complex vitamins, and that's folic acid, B12, and B6. In fact, those people in this study, in this randomized trial, showed a rate of shrinkage or atrophy of the brain slowed by 53% in the active treatment group. They also had improvements across memory and other cognitive areas. So the take-home point here is, you know, for example, when this was studied, B vitamins were studied in people with dementia due to Alzheimer's disease back in 2008. B vitamins did not have any effect in a randomized controlled trial. But if you use B vitamins in the earlier phases of cognitive decline before dementia, and you look in a targeted way for people that have elevated homocysteine, then it did work. However, again, here we go again with single or multi-nutrients, the person absolutely also had to have sufficient amounts of omega-3 fatty acids in the blood to work combined with the B vitamins to slow brain atrophy and improve cognitive function. So this, again, kind of expands precision nutrition in my mind when it comes to brain health, because it's not just about the genes, it's about everything else too. So when we talk about evidence, we should also think about the positive evidence, the confirming evidence, as well as the disconfirming evidence. And the FINGER study was a multi-domain intervention study, a 2-year trial, looking at the combination of nutrition, exercise, cognitive training, and ongoing monitoring with a healthcare provider. And in this study, after 2 years, it was able to show that we can actually positively impact and slow cognitive decline. And this was a really important study, the first of its kind. It really, you know, changed our field for the better. But another study a few years later showed that, wait a minute, when you tried these multi-domain interventions and you either added omega-3 fatty acid from a supplement or didn't, there was no difference between groups. And we have to take a look at this, because, you know, why did it work in one study? Why didn't it work in the other? Well, in this study, the MAP study, it was an older population. The dietary intervention and exercise interventions, they were actually different. The omega-3s that were given were pretty low. That really probably wasn't enough to move the needle. It was also probably given too late. It was an older population. They were more frail. Maybe this needs to be shifted earlier in the pathology. And then also omega-3s were given as a one-size-fits-all. They didn't do a blood test. They didn't do a red blood cell level of omega-3 fatty acids, and if you were low, then you were given omega-3s. They didn't do that because, again, this is a one-size-fits-all, and I think where the field of brain health and precision nutrition has to go is understanding that there is no one-size-fits-all approach. We're going to focus now mostly on omega-3s because the level of evidence is really nicely developed. And for those of you in the audience, I think it frustrates many of us when we talk about omega-3s and fish oil and supplements. And this is a very confusing topic. The better term that I like to use is omega-3 fatty acids or polyunsaturated fats. Not all fish oil is created equal, that's for sure. We can talk about that at length, but it's a confusing topic when it comes to brain health because, first of all, most of the research shows that the dietary intake from fatty fish wild salmon, sardines, and the list goes on and on. Dietary intake from fatty fish at least once or twice a week is pretty strong for brain health. But what about a dietary supplement? And should it be a prescription version? Does it need to be over the counter? These are very confusing things, especially for patients. When it comes to dietary types of omega-3s, again, the devil is in the details. DHA, sure. EPA, yeah. But what about ALA? ALA probably doesn't move the needle much at all when it comes to cognition and brain health, but DHA more so than EPA in terms of evidence. But the evidence, we need to clarify this, especially for patients and also for science. They may preferentially work depending on genes, and we'll talk about that shortly. People with the ApoE4 variant may be preferentially set up to work if they take omega-3s, but it needs to be at the right dose. It needs to be given the right way over the specific period of time before symptoms. Again, we'll talk about that soon. And it may also depend on omega-6 to omega-3 ratio. So when it comes to precision nutrition, everything, the devil is in the details. So a major question that I think we have in our clinic and in our world is that can omega-3 consumption, and specifically in ApoE4 carriers, help the brain before onset of disease? And there's been, again, inconsistent evidence. Some studies show one thing, other studies show something else. But from a practical clinical perspective, what I'm looking for as a doctor treating patients at risk is also, what is the optimal dose of DHA to get into the brain? Do ApoE4 carriers, do they have a brain delivery deficit of DHA before the onset of cognitive decline? And do ApoE4 carriers benefit from DHA to prevent or slow cognitive decline in Alzheimer's? So how do you figure this out? You have to spend a lot of time and really develop an elegant program of research. And Dr. Hussein has shared some slides, and I'll be talking about one of his recent studies. But what his work and others have come to conclusion as is that diet, ApoE4, and aging, timing matters. It really depends. Using a healthy lifestyle and dietary changes depends on when you intervene. The earlier, the better. That's one take-home message. When it comes to omega-3 intake, when you look at the timing, well, earlier is really better. For example, at the age of 35, cognitively unimpaired, meaning normal 35-year-olds with an ApoE4 variant, have an increase in brain DHA uptake when looked at on PET scans. This suggests that there's a compensation for brain DHA deficiency, and this implies a vulnerability to a low DHA diet. Then what do you need to do? Intervene early. So Dr. Yasin and colleagues published a really elegant paper just a few months ago, where they basically gave DHA in sufficient, in anyway, my opinion now, sufficient doses of over 2 grams of DHA. They also gave all of the subjects in the study B complex, because we wanted to, take that out of the equation, because if some people have a high B complex, a low B complex, from a biological perspective and a biochemical perspective, you're going to get, mishmashes of results. So in this study, they basically showed that people with the ApoE4 variant really needed these high doses in order to get into the spinal fluid. So the interpretation of this aspect of his work, where they actually did spinal taps on people in this randomized study, is that dementia prevention trials using omega-3 supplementation in the past at low doses, less than 1 gram per day, just aren't going to really move the needle, especially in people with the ApoE4 variant. So to truly understand this, we need to go many steps further. So what we do in our clinic and in our clinical practice and our research program is we adopt a comparative effectiveness research approach, where we try to translate the greatest hits of prior evidence into real-world clinical practice, and then we study it quite closely. This is what we call the ABCs of Alzheimer's prevention management, where we look at the A, anthropometrics, body fat, muscle mass, blood-based biomarkers of Alzheimer's and cognitive dysfunction risks, so lipids, inflammation, metabolism, nutrition, and genetics, and then pretty careful cognitive testing. And we basically do this every 6 months, and we refine or fine-tune our targeted, individualized interventions, and we pick which interventions to give based on the evidence, balance and safety, and balance with what specifically is deficient in the person sitting in front of me. Again, precision nutrition, precision medicine. And this is what we do. Pretty simple, right? Well, I don't know how simple it is. There's a lot of stuff going on, but it's if this, then this, if that, then that. Cross-reference this and cross-reference that. And a major part of our intervention, of course, is using elements of the emerging science of precision nutrition. So we published our findings about a year or so ago in the Journal of Alzheimer's and Dementia, the Journal of the Alzheimer's Association. And this study was really the first empirical trial in a clinical setting showing that individualized Alzheimer's risk factor management with an emphasis on precision nutrition, as well as other lifestyle interventions, stress reduction, exercise, blood pressure control, diabetes management when needed, management of cholesterol, sleep, of course, is super important. This can actually improve cognitive function related to Alzheimer's pathology. And in this study, our patients in the study were followed over 18 months and on average got 21 different interventions, and a lot of those were based in nutrition. Secondary analyses showed reductions in calculated Alzheimer's and cardiovascular disease risk, and we also showed an impact on age-related cognitive decline. So in terms of conclusions, I think the building blocks of our understanding of precision nutrition are there for cognition and Alzheimer's risk, but we have much more work to be done. Programs of research like Dr. Smith and Dr. Yersin are an ideal model for future progress. We really need to have a concurrent emphasis on real-world comparative effectiveness studies like in our clinical program. We just don't have time to wait. And funding opportunities for this type of work are critically needed. I wanted to end briefly in that education about nutrition is important, and we've really spent a lot of time on this. We have a free website. It's an IRB-approved education research study called alzu.org, where we have courses for students, college students, high school students, the general public, and even physicians to explain what is and what is not in our control when it comes to nutrition and brain health. And not surprisingly, the most really popular lessons are all about our series with the brain healthy versus unhealthy content. Thanks so much.
Hello, I'm Marianne Sevick from New York University School of Medicine. It's a pleasure to speak with you today about the promise of precision nutrition for the prevention and management of type 2 diabetes. I want to thank the organizing committee for this invitation and acknowledge the work of our multidisciplinary team. In order to understand the promise of precision nutrition, it's important to understand the nature of type 2 diabetes. While the underlying mechanisms of the disease are not entirely understood, these graphs show the typical trajectory of the disease. The bottom graph shows that at around 10 years before diagnosis, we see the development and progressive worsening of insulin resistance. Increasing amounts of insulin are required to keep blood sugars within normal range. Early in the disease, pancreatic beta cells can compensate by producing extra insulin. This higher insulin production promotes fat storage, resulting in even greater insulin resistance and a vicious cycle of weight gain that eventually results in beta cell exhaustion. When beta cells are no longer able to compensate, hyperglycemia becomes apparent and diabetes is diagnosed. Following diagnosis, you can see that insulin resistance remains constant, but beta cells continue to deteriorate and eventually they fail altogether. And what we see clinically is a deteriorating picture of glycemic control with more and more medications required in order to maintain blood sugars within normal range. Many patients will eventually require insulin. Controlling glycemia is important because we want to protect beta cells from burnout. We know from the Diabetes Control and Complications trial in type 1 diabetes that even minimally preserved beta cell function is associated with better outcomes. In addition to preventing beta cell burnout, we want to minimize glucolipotoxicity. Glucose exposure in combination with elevated levels of free fatty acids that are commonly observed in obesity appears to be directly toxic to beta cells. Poor glycemic control results in cumulative irreversible vascular damage that lead to the complications of the disease. And finally, there's evidence from large clinical trials that minimizing glycemic exposure in new onset diabetes has beneficial effects that last for many years, regardless of the glycemic control that is achieved later in the course of the disease. This is referred to in the literature as metabolic memory. The risks of diabetes and its vascular complications vary by race and ethnicity. While the reasons for these disparities are not clearly understood, a few studies suggest that there may be underlying differences in glucose metabolism. Several studies have shown that Hispanic and non-Hispanic Black individuals are more insulin resistant than non-Hispanic whites, independent of adiposity and body fat distribution. A few studies also showed that Hispanic and Black individuals have a much larger acute insulin response than non-Hispanic whites. This figure shows a meta-analysis of 74 studies, including 3,800 people that employed frequently sampled blood in conjunction with an oral glucose tolerance test. And you can see that smaller increases in insulin resistance were associated with a much larger acute insulin response among those of African descent. This larger acute insulin response may contribute to observed racial disparities in obesity, diabetes, and some diabetic complications. The luteal phase of the menstrual cycle has been shown to be associated with lower insulin sensitivity and higher fasting glucose in some, but not all studies. Multiple federally funded clinical trials have been performed to examine the impact of aggressive medication management on diabetes outcomes. UKPDS enrolled participants with newly diagnosed diabetes and showed that reducing A1C was associated with lower risks of microvascular complications. Subsequent studies enrolled patients with longer-standing disease and those who were at high risk of or who had already developed vascular complications of diabetes. The results were mixed and mostly negative. The ACCORD study and the Veterans Affairs Diabetes Trial raised concerns that severe hypoglycemia from aggressive medication management increased the risks of major cardiovascular events, cardiovascular mortality, and all-cause mortality. And as a result, in 2018, the American Diabetes Association revised their standards of medical care to note that in further lowering A1C from 7 to 6%, the risks of polypharmacy may outweigh the benefits. And the American College of Physicians recommended that patients with diabetes be treated to achieve an A1C of 7 to 8% rather than the widely accepted range of 6.5 to 7% because of the potential risks of intensive medication management. But it's important to keep in mind that by enrolling people with well-established disease and those at risk of poor diabetes outcomes, it was perhaps too late in the disease trajectory for these studies to prevent adverse metabolic memory effects that led to downstream complications of the disease. And with the exception of the Heart-2D study, all of the studies targeted fasting glucose or A1C. In early type 2 diabetes, blood sugars and A1Cs are often within normal range and perhaps are the wrong target. According to Monnier, dysglycemia should be thought of as having three distinct components. Ambient hyperglycemia is sustained background hyperglycemia. Hypoglycemic episodes are adverse consequences driven mostly by medication. And glycemic variability refers to glucose fluctuations from peaks to troughs, with glucose peaks reflecting postprandial glycemic excursions. In early type 2 diabetes, postprandial glycemic response accounts for about 70% of glycemic exposure. And compared to ambient hyperglycemia, these glucose fluctuations result in greater oxidative stress, are more damaging to human endothelial cells, and are a greater contributor to adverse metabolic memory effects. Together, this literature suggests that in prediabetes and early stage type 2 diabetes, where there's the greatest likelihood of preserving beta cell function and preventing adverse metabolic memory effects, the regimen should emphasize postprandial glucose management. And there is universal recognition that dietary management is key to successful type 2 diabetes treatment. Numerous clinical trials have been conducted on low carbohydrate and low glycemic index diets, and the results have been mixed and mostly negative, perhaps because they all used one-size-fits-all dietary prescriptions that did not take into consideration the fact that individuals vary greatly in their glycemic response to the same food. A stunning example of this, in a fasting sample of non-diabetic adults, Mendez-Suarez used continuous glucose monitoring to demonstrate large between-subject variability in glycemic response to the same breakfast of a bagel with cream cheese. Meal timing can also contribute to dysglycemia. In a crossover study in healthy adults, Luang et al. Examined plasma glucose and insulin levels at baseline and at 30-minute intervals for 3 hours, following exposure to the same low glycemic index meal consumed at different times of the day. They found that plasma glucose exposure was significantly lower when the meal was consumed at 8 a.m. than either 8 p.m. or at midnight. An insulin response was lowest for the meal when consumed at 8 a.m., followed by the 8 p.m. meal, and highest following the midnight meal. Several studies have also shown that the sequence of macronutrient consumption during a meal can affect glycemic response. This figure shows the results of a randomized clinical trial in which 35 participants with normal or impaired glucose tolerance or newly diagnosed diabetes were randomized to receive one of two conditions 30 minutes before an oral glucose tolerance test. One group received 500 milliliters of water, while the other consumed 50 grams of cheese and a hard-boiled egg. You can see that the fat and protein preload substantially reduced glycemic exposure, particularly in those with type 2 diabetes. And then, of course, there's a lot of new and exciting research regarding the role of the gut microbiome in the development of diabetes and obesity. In a series of mouse studies, Turnbaugh and Lay concluded that the obese microbiome has an increased capacity to harvest energy from the diet. Others have shown the composition and function of the gut microbiota to be associated with glucose intolerance, insulin resistance, and type 2 diabetes. Radara transplanted fecal microbiota from human twins discordant for obesity into germ-free mice. The mice receiving the lean twins microbiota remained lean, and the mice receiving the obese twins microbiota developed obesity and related metabolic phenotypes. And Vries showed that transfer of intestinal microbiota from lean humans to humans with metabolic syndrome increased their insulin sensitivity. So building on these observations, in his 2018 Cell paper, Siegel published the results of a machine learning-based algorithm that predicts postprandial glycemic response using the gut microbiome, laboratory data, a questionnaire, a one-week log of food intake, and continuous glucose monitoring. The model predictions were highly correlated with measured response and substantially higher than naive predictions based on the meal's carbohydrate content alone. And we're currently using the PNP algorithm from Siegel's work in a weight loss study in people with prediabetes and type 2 diabetes. We're comparing a personalized versus a standardized low-fat diet. Both groups have the same calorie restriction. Both groups receive the same behavioral counseling. Both groups self-monitor dietary intake using the same mobile app. The standardized group gets dietary feedback on total calories and calories from fat, and they use this to adjust their dietary intake, whereas the personalized group gets the same feedback, plus they get a predicted postprandial glycemic response score to every meal and snack that they enter, and we train them to make meal adjustments to lower their glycemic exposure. We're currently in the final year of this trial, and we're unable to unblind the results at this time. But early in the study, after the first 36 people were randomized and completed their 3-month assessments, our preliminary analyses suggested a statistically significant between group difference in the mean amplitude of glycemic excursion favoring the personalized arm. In a recent 2-phase pilot study, Siegel's group examined the impact of the PNP algorithm on glycemic exposure in 21 patients with type 2 diabetes. In phase one was a crossover study in which participants experienced 2 weeks of the PNP guided diet and 2 weeks of the American Diabetes Association Mediterranean diet, with the ordering of diets randomly determined. And in phase 2, all participants then proceeded to 6 months of the PNP guided diet with clinical laboratory measurements repeated at 6 months. This figure shows the individual within subject glycemic exposure for the PNP guided diet in green versus the ADA guided diet in red. Across the top of the figure, p-values are shown for within subject differences, and you can see that the glycemic exposure was significantly lower for 13 of the participants and marginally so for another 2. Overall, in phase 1, glycemic exposure was significantly lower in the PNP guided diet than the ADA guided diet. After following the PNP algorithm guided diet for 6 months, statistically significant within subject improvements were observed in the mean amplitude of glycemic excursion, A1C, fasting plasma glucose, fructosamine, triglycerides, insulin, and insulin resistance. So in summary, type 2 diabetes poses a significant public health problem. Clinical trials of aggressive medication management regimens to achieve near normal fasting blood glucose and A1C have been mixed and may increase the risk of adverse outcomes. In early diabetes, management of postprandial glycemia is particularly important for minimizing metabolic memory effects and preservation of beta cell function. Postprandial glycemic response is highly individual and appears to be predictable. Using precision nutrition methods, it may be possible to personalize dietary recommendations to reduce glycemic exposure, enhance our ability to prevent type 2 diabetes, and better manage the disease. Thank you for your attention.
Hi, my name is Emily Ho, and I am faculty and the director of the Lawrence Pauling Institute at Oregon State University. I want to thank the organizers and to NIH for organizing this important workshop on precision nutrition. My research focuses on nutrient genome interactions in cancer prevention, and I'm going to talk a little bit more about the progress, opportunities, and challenges that currently exist in the area of precision nutrition and cancer prevention. So the influence of diet and nutrition in cancer has been long known. In one of the seminal papers from Dole and Pito in the 80s, they postulated that perturbations in diet contribute to more of the cancer cases than other well-known agents, including smoking. However, the relationship between diet and cancer is highly complex and complicated. There exist factors in the diet that could be cancer-causing, as well as dietary components that could be lacking in the diet that are protective. So the interactions of diet and cancer are multifold and extremely complex and multi-targeted. These dietary factors, in fact, play a role in more than just the initiation of cancer. They also play a role in limiting progression, promotion, recurrence, and also have an influence on the effectiveness of therapies. So where does nutrition make a difference? Similar to other chronic diseases, cancer etiology and progression is a multi-level and multifaceted process. There are multiple levels of dysregulation, some that may be consistent hallmarks in an at-risk patient, but there are also high variability depending on stage of cancer, cancer type, and the individual. Luckily, there are also many potential targets and mechanisms that diet can influence, including many of these listed here. The American Institute for Cancer Research and the World Cancer Research Fund have worked tirelessly over the last several decades to identify food, nutrients, and food patterns that are consistent for cancer prevention. Some examples are shown here. Similar to the USDA MyPlate recommendations, however, these recommendations are also generally broad and tend to take a one-size-fits-all approach. In addition, despite decades of research and significant amounts of preclinical data, there has been more limited success with specific nutrient interventions in randomized controlled population intervention trials. Some examples include the beta-carotene trials in lung cancer, the SELECT trial using selenium and vitamin E in prostate cancer, where despite strong preclinical evidence, the results of these trials were somewhat disappointing. There have been many lessons learned from these trials, and in particular, a thought that we need to consider individual needs, and consider both the characteristics of the host and the cancer microenvironment to really understand why there's such a wide variability in response, and also consider interactions from outside factors, including how age, the microbiome, and other environmental influences all work together to be able to develop a more targeted plan to improve efficacy of these nutrients in cancer prevention. So where are we in realizing personal nutrition and personalized medicine in cancer? The concept of personalized medicine for cancer prevention and treatment has been a hot topic for quite some time. And in particular, the advent of the changes in technology to really look at the cancer genome on a full genome scale has really revolutionized our ability to discern the effects of genotype on cancer progression. Genotype has been used to help customize therapy options to, for example, predict drug safety, toxicity, as well as efficacy. We've also used gene profiling or genotype to develop what are called gene prognosis signatures that really identify more targeted strategies and identify patients that would benefit from specific types of therapies. For example, in breast cancer, genotypes that are consistent with ER responsiveness are a major driver in terms of treatment strategies. In the field of nutrition, the thought is nutrigenomics be used in a similar fashion. Given that we know that genetics play a role in terms of how nutrients are metabolized, can this be used to better personalize nutrition-based interventions that will potentially aid in the prevention of cancer and or help delay the progression of the disease as well? However, when considering personalized nutrition, there are again many complexities. I've already mentioned the complexity of food and nutrients, and that whether or not single agents or multiple targets are going to be needed. The complexity of cancer etiology and the variability that's associated with cancer stage and cancer type. Another aspect of this complexity is that although cancer has traditionally been considered to be a genetic disorder, genetic mutations and genotype are not the only factors to consider. In particular, the field of epigenetics has really caused a big paradigm shift in terms of the way that we think about cancer etiology and potential therapeutic targets. This has caused, again, a big paradigm shift in terms of how we can develop strategies to target epigenetic or outside the DNA changes that also result in this dysfunction that leads to cancer. What's also important is that there are several components of our diet that are also able to target this epigenetic dysregulation and play an important role in cancer prevention. The thing that I do want to note, though, that it appears that metabolism is going to be key in terms of generating the bioactive metabolites that can exert these particular effects. So what do we need to look at in terms of realizing personalized nutrition and cancer prevention, and what do we need to think about? So first and foremost is how can we understand what are the sources of variability in response? And in particular, centered around this is understanding what are the bioactive forms that are able to target these key mechanisms in cancer progression and or prevention. Is individual compound versus multiple compounds versus multiple targeting going to be needed? What are the differences between food sources versus supplement sources? And the third point here, especially, how do we influence individual variability? What are the determinants of this variability, both looking at the host metabolism and the influence of the microbiome? Each of these influence this flexibility in metabolic response that will alter potential efficacy. How do we also consider cancer stage? Do we look at primary versus secondary prevention? Also, how do we look at potential role of nutrients with existing therapeutics for cancer as well? We really need to look at how, if we really want to realize the promise of personalized nutrition, we really need to combine all these factors, genotype, nutritional status, epigenetics, and metabotypes to really identify the optimal path forward. And to do this, we need to looking at things in a different way. We know that multiple influences all come together in terms of driving the susceptibility of an individual to cancer or many other chronic diseases. And the thought is that diet and nutrition may be able to help push on this dial and overcome some of that susceptibility and increased risks. However, in reality, for each individual person, this dial is going to move in a different way. So we need to consider multi-scale effects and again, move away from this one-size-fits-all and to really do this and really consider how diet interplays in this entire system. We need a different integrative approach. So although diet and cancer has traditionally focused on primary prevention, I also want to take a moment to highlight the increasing body of evidence that also includes the influence of diet on secondary prevention and treatment interactions. So for example, there's been intense interest in the use of immunotherapy and immune checkpoint inhibitors for the treatment of several different cancers. One of the pitfalls of this therapy is that there is a high proportion of non-responders to this therapy. And there's a critical need to identify determinants of this non-responder phenotype. More recently, the role of the microbiome has received increasing attention as a driver of this responder versus non-responder effect. And given that nutrition plays an important role in both the maintenance of immune system, which is important for this response, this therapy to work, and also the microbiome. It wouldn't be surprising in terms of how nutrition could be a critical determining factor in terms of efficacy. In fact, the role of microbial metabolism is another aspect that increases the complexity of these variation of individual responses to nutrients. The generation of active metabolites is going to be key for chemoprevention and successful response. And we need to better understand the determinants from both the host and the microbe and their interactions to really get a better appreciation of how this comes into play for cancer prevention. So to really realize the potential of personalized medicine and personalized nutrition, we need to realize that there is not a one-size-fits-all. And to really understand the sources of these variability, a highly integrated and holistic approach is needed that together will influence one's overall health. There have been huge technological advances that allow us to capture a whole host of different types of data, including genetics, genome, epigenome, metabolomics, the microbiome. However, there are still some significant barriers in terms of being able to integrate diet into this holistic picture effectively. There needs to be some priority put on biomarkers, both for early disease and biomarkers of nutrient intake. If we can identify specific nutrient needs, especially early in disease, this could have a huge impact in terms of cancer prevention. The National Cancer Institute has taken significant strides in terms of taking this holistic approach to an integrative approach for cancer diagnosis and treatment. Last year, the NCI funded a new consortium called the Center for Cancer Data Harmonization. This is a national multi-institutional effort that's co-led by one of my faculty, Melissa Handel. And this consortium really leverages the existing cancer research data commons and electronic health records. And what's been striking to me is that dietary data is something that is missing from a lot of these data sets. So there currently exists a huge gap in our capacity to leverage existing data and include dietary parameters. In addition, a lack of standardized methods to be able to capture and categorize dietary data effectively, so we can effectively integrate dietary data into these other cancer phenotypes. To be able to leverage these complex big data approaches, there again are some significant barriers. For this integrative data approach to work, the current dietary data needs to meet some fundamental criteria that it currently does not. So here are some listed here. In particular, the FAIR concepts, the findable, accessible, interoperable, and reusable concepts, all need to be significantly addressed to be able to effectively harmonize and integrate dietary information to these data sets and better move towards personalized nutrition for cancer prevention. So in closing, there are the promise of personalized nutrition for cancer is strong, but there's still a lot of work to be done. Here are some food for thought, but I look forward to hearing more from the other speakers, the panelists, and all of you to work towards solutions on this important issue. Thank you.
Okay, well, welcome back to the live part of the section. And now we are going to go into the question and answer time. I think we have time for a few questions, so don't be shy. I'm sure you have many of them, so just write them under the screen. Let's start. It seems like the ApoA2 polymorphism and dietary fat has raised some interest, and we have some questions about that. One of them is, what is the population prevalence of CC in the US? And are there differences by various subgroups, like African Americans and so on? Well, the answer is yes, there are differences. But in terms of European, the allele frequency is about 39%. For African Americans, it's a little bit lower, around 0.22%. And then the Asians is probably the lowest, with about 10%. And then Hispanic is 27%. So you see that there is a wide range of variability. Europeans are the one which is more abundant. How that translates into that specific question, the prevalence of CC, is, for example, out of 1,000 people, 164 will be CC. So that's the population, the size of the population in which these more precise recommendations in terms of saturated fat will work, right? And that brings us to the other issue about how important it is for the future of precision nutrition not to just rely on research from one single ethnic group, because obviously there are huge differences in some cases in terms of allele frequency. So that was one of the questions. And the other one was, do you think there is enough evidence to test ApoA2 SNPs for providing saturated fat advice related to weight BMI to patients in clinical practice? If no, what more evidence do you think we need? Well, again, the information that you have seen, I think is enough to think that this is happening, this is real. However, as scientists, and I reminded of that during my presentation, we have to look for the greatest or largest level of scientific evidence, meaning an intervention trial. And everything that we know so far is based on observational data or results. Therefore, I will feel a little bit ambivalent about taking this to the clinic at this point without having the demonstration that if you change the diet according to the genotype, as as suggested, we can have the beneficial effects that we have seen in observational studies. So that will be my answer. Optimistic, but probably not ready to take off with this in terms of the clinical practice. Okay, the questions are arriving. Great. I guess this is for Mary. Could you provide the full reference for the 2018 ADA statement about the risk of polypharmacy outweighing the benefits of lower glycosylated hemoglobin? Mary?
Yes, I think it's in the 2018 ADA update for their standards of medical care.
Okay. Let's see. This question, I see ApoE, so probably is for Isaac. As genome sequencing is becoming a more mainstream practice in genetic disease clinics, in particular for rare diseases, how do you see genetics being integrated into more general clinical practice for more complex diseases? What are the ethical barriers for this, in particular for the individual ApoE4 status?
Great, really important question. And, with commercial genetic testing out where really anyone can find out their ApoE status by sending in their saliva to a variety of different commercial kits, I think it's important that this question comes up. First of all, back in about over a decade ago, the REVEAL study showed that people that found out disclosure of the ApoE4 variant status had no long-term deleterious effects on psychological outcomes. There was a little bit of a increase in anxiety when someone first learned about it. But it's important, when it comes to ApoE, ApoE4 variant is not a deterministic gene. If you have it, it doesn't mean you're going to get Alzheimer's, and if you don't have it, you can certainly get Alzheimer's. So when it comes for, in our clinical practice, we give very specific counseling about this and education. We also, I gave that website where all of our patients, before they come in, have to watch online education about Alzheimer's disease and genotype and what is and what is not predictable based on it. So from an evidence-based perspective, I believe that ApoE4 disclosure, and the FDA tends to agree with this too, is okay. When it comes to whole genome sequencing, this is tricky. We're dabbling in this. We've done whole genome on literally less than a dozen patients. And we find so many things that we have no idea what to do with. So when it comes to whole genome, I think it's different. I think, that's not exactly ready for prime time yet. I will be honest, I have found some important genes that would, in an ideal world, would change management decisions. I'll be honest about that, but it's not super common. Doing it in a CLIA certified lab is better than obviously. But these are really complicated questions. E4, I really believe, can be integrated into clinical practice and patient care today. That's a very complicated and controversial opinion, though.
Okay, Richard, as we have you already there, I have another question for you. I am a PhD student working on AI-assisted healthcare. It seems like nutrition advice for Alzheimer's depends on ApoE4 gene. In that case, how was the evaluation done for existing studies? Thanks.
Yeah, so the best review, we wrote a review on this in the Journal of the Prevention of Alzheimer's Disease. The first author is Berkowitz. He was a former med student of ours, and it was published in 2018. And it's basically ApoE in clinical practice, an overview of the evidence. How we do the evaluation for E4, just to make sure I'm answering your question, we use commercial-based testing. It's very easy and very cheap to get ApoE. You can run 4 at a time for $100, so $25 each, or even cheaper. And when we get the results, there are certain things that we tailor. We may pay more attention to omega-3s, for example, and dose. We may pay more attention to other aspects. I think this is still very early. I think it's very preliminary, but I think it's something we think about literally with every patient.
Thank you. Can Dr. Sevick please comment on the mean macronutrient composition and glycemic loads of the personalized versus the comparison diets in the trials for glucose management in type 2 diabetes? If these differ, how do we know that the benefits were due to personalization versus the macronutrient composition?
Well, that's actually a good point. And I think that with personalization, to reduce postprandial glycemic response, there are likely going to be reductions in a carbohydrate intake and glycemic index. And that is definitely one of the things that I think will be difficult to disentangle, but not impossible. But I think that's a very good question, and one that I don't know the answer to.
Thank you. In omega supplement studies, has the gamma tocopherol isoform considered in design and interpretations? Because gamma tocopherol has evidence of increased inflammation responses. Who wants to take this?
I'm not sure. I did talk about omega-3s quite a bit. I'm not sure if that was directed to me. I'm just a brain doctor. I'm a neurologist by trade. So I would love to defer to the other experts in the field to this question.
Let me see if there is another related question. Let's see. To add to the gamma tocopherol question, gamma tocopherol is added to omega supplements to prevent oxidation, but gamma tocopherol is shown to increase inflammation. Anybody wants to take that? Let's move on. In terms of data harmonization, are there suggested validated intake tools to better standardize the dietary intake information across studies?
Yes, that's the million-dollar question at the moment. And to be honest, at this point, we are behind the 8 ball in terms of having those tools. I mean, the current standardized tools are reliant on survey data, food frequencies, 24-hour dietary recalls, and hopefully part of the initiative that we'll hear about later, we'll be able to hear a little bit more about proactively trying to standardize some of these intakes so we can better utilize some of these existing data sets and integrate nutrition, but we unfortunately aren't there quite yet.
Okay, there is a related question. It is exciting to see the data harmonization efforts from your team for nutrition cancer research. There are other ongoing dietary data harmonization projects based on longitudinal randomized control trials and observation studies for chronic disease. Would these dietary harmonization efforts be complementary to your team efforts? If so, would you expect there will be a time for harmonization projects come together?
Yeah, no, that's a great question. I think there has been efforts across a lot of the other chronic diseases. Most recently, especially with COVID crisis currently, there has been some very strong initiatives to look at, for example, dietary supplements, vitamin D, and other nutrients in relation to COVID infection. So the current pandemic has also kind of moved forward in terms of some of these efforts. So hopefully, in terms of a time frame, I'm not certain where we're going to be, but there is definitely a lot of interest in efforts, and hopefully we'll get there in the coming years.
Thank you. Well, we are reaching the time in which we have to end the Q&A to move into the panelists, but there is a question here that seems interesting. Public health efforts in the US have enough challenges with achieving adherence to very basic nutrition recommendations. While the field of medicine barely utilizes nutrition prescription largely due to the lack of training for physicians, is personalized nutrition really the most important next step forward? What do you feel are the most important changes to implement to make this information actionable? Phew, I don't know if anybody wants to tackle this very briefly, or I think this is something that will be answering through the different sections, and we'll return to that in section number 6. But if anybody wants to express the opinion, brief opinion now, we can do it, or otherwise we move to the panel section. Anybody?
I mean, I have a very biased clinical practice, but the people that come to me really want to learn more. So I think in my case, sure, I think precision nutrition and personalized nutrition, we have to, keep going down the path. I think also digital therapeutics, digital tools, artificial intelligence, we're going to be able to use technology to offer this personalized information. So we need to figure out the rule set in order to deploy that information. So I do think we need to, over the next several years.
Okay. Well, there is one more. What are the possible implementation issues with precision nutrition, where even proper nutrition is not available? Mary, you want to take that?
Could you repeat the question, please? I'm sorry.
Yeah. What are the possible implementation issues with precision nutrition, where even proper nutrition is not available?
That's a really good question, and I think that when you talk about doing dietary counseling of individuals using precision nutrition, you start with them where they're at in terms of what are their current dietary patterns, and then how are they responding to the current components of their meal. And what you can do is you can perhaps guide them in a direction by identifying those factors that contribute to a high postprandial glycemic response, in my case, guide them to different dietary choices within the realm of foods that are available and acceptable to them. But with that being the case, I think it's clearly an issue that clearly adequate nutrition is it's something that I don't deal with well in clinical trials, and it's something that we definitely have to address.
Okay. The reason why we have the luxury of contemplating a few more questions is because we have some technical issues with 2 of the panelists, so we have a little bit more time for the Q&A. Let me see. The N6-N3 ratio was developed based on theories that have now been shown to be incorrect and full of wrong assumptions. Does Dr. Isaacson have evidence for N6 fatty acids? Have evidence that N6 fatty acids are detrimental? If so, how might we reconcile this in the context of the benefits of N6 PUFAs for heart disease and cholesterol regulation?
I'm glad you asked that. Sorry, my slide or my talking may not have been clear because I was trying to get through the material quickly. I'm pro omega-6 fatty acids. I believe they are positive. They are helpful. It depends on which study you read, of course. I think they're more helpful for Alzheimer's disease than some of the other subtypes of dementia. So that's Alzheimer's disease and maybe vascular disease, for example. So I do think omega-6s are positive. But what I've seen in my clinical practice, and I don't think we have the best data for this, is the mismatch of omega-3 and omega-6. I honestly think both of them should be high, and if both of them are high and the ratio is, I'm really guessing here, but 2.5 to 1 or better, or 3 to 1 or better, I don't really know. I'm making that up, but from my clinical experience, those are the patients that seem to do better. I'm pro omega-6s, so sorry if that wasn't clear.
Thank you, Richard. Okay, why don't we move to the panelists? And I am sure there will be some of the unanswered questions that the panelists will be able to answer. And then we are not going to have Dr. Franz and Dr. Clinton for technical difficulties, but still we are going to start with Linda. So Linda, go ahead.
Thank you, and hello everyone. Thank you so much. It's a privilege to participate in this exciting workshop, and I'm delighted to have this opportunity. Thank you. And as you, Dr. Ordovás stated in your presentation, we are complicated, especially as this audience knows. The role of nutrition complicates us further, therefore presenting us with endlessly fascinating but challenging questions regarding the best approach towards unraveling these complexities. Only by recognizing the various contributors to this process can we reasonably identify the best and most appropriate dietary prescriptions to achieve optimal health for uniquely created individuals. With that in mind, my own research focuses primarily on cardiometabolic health over the life course, aimed at preventive and therapeutic dietary recommendations. And you have heard many presentations discussing this important focus using nutrigenomics that are involved in developing a precision nutrition approach. I'd like to just place that within the context of some of these accompanying aspects that equally contribute to the desired outcomes for both understanding and developing appropriate prevention and treatment approaches. As is illustrated in this slide, I'd like to draw attention to the importance of dietary assessment, in itself a complex combination of documenting and analyzing many different aspects of foods, nutrients, and behavior. As reported this past July by the 2020 U.S. Dietary Guidelines Advisory Committee, standardized approaches to dietary assessment are key to conducting systematic reviews and meta-analyses that contribute to the developing diet recommendations. Just as there is no one Mediterranean diet, for example, and all you have to do is think of the differences between Spain and Greece and other cultural applications of that region, there really are many different reasons why assessment of dietary intake remains important. And despite what has been emerging over these last couple of years in regard to the importance of the dietary pattern, that does not exclude the importance of the nutrients that are presumably fostering the mechanisms that underlie that. So as you see illustrated in the slide, the diet assessment data comparing existing and future cohorts that we have available to us really offer a potpourri of different types of dietary data for inclusion in this precision nutrition approach, ranging from nutrients to foods, food groups, dietary patterns as indicated in terms of capturing this. And of course, we all recognize the differences in terms of interpretation and application to a patient population, for example, as well as scientifically understanding the underlying mechanisms, et cetera. And not to mention the culturally and age relevant tools needed to capture diet assessment across the life course that gets at the macronutrient composition, as well as the vitamins, minerals, and ratios of these nutrients that are emerging as having a greater importance. And also the non-nutrient composition, including things like polyphenols and dietary fiber and the short-chain fatty acid promotion, as well as fermentation and plant versus animal-based sources of carbohydrate and protein. And then, of course, questions that continue to rage in regard to cardiovascular disease related to saturated fat versus replacement with either monounsaturated fat or polyunsaturated fat, and understanding the variability that takes place in individuals. And also then looking at processed versus whole foods, which of course now in our current population have a tremendous influence on how individuals respond. And then, as was mentioned earlier, even questions related to meal timing and how that influences our outcomes. So as was discussed, and you see in the yellow, the omics that again, Dr. Ordovás and others have already focused upon, looking at those elements of genomics and diet are extremely important, as well as the other lifestyle factors. And again, we have currently in the United States an overweight and obese population. Starting in 2010, the U.S. dietary guidelines could no longer really look at those recommendations for a quote-unquote healthy American public. We're overweight and obese. And so the different responses to different dietary recommendations clearly need to be tailored to those individuals, as well as looking at very important factors related to physical activity, sleep behavior, substance abuse, some of the cultural traditions that we talked about, and stress, which was, of course, also indicated. And then all of this relates to what's known as systems epidemiology, which Cornell and Hu reported in terms of identifying this range of different approaches and contributors to developing this precision nutrition focus and identifying both the preventive and the treatment-based recommendations. And if we can go to the next slide, I'd simply like to illustrate that from my perspective, looking at the preservation of ideal cardiovascular health, this really begins in utero. The more we read about maternal fetal nutrition, as well as the contributors to pediatric obesity, which we all recognize as the trigger that is involved with developing comorbidities over the life course, we have our work cut out for us. And while it's tempting to say we got to start, in utero, and if you don't start there, all is lost, that's really not true. And again, as we look at these systematic reviews and meta-analyses that are introduced later in life when these risk factors already exist, I would conclude that it's never too early, but it's also never too late to begin eating a diet that is more consistent with the recommendations that are being made on the basis of the diet and now increasingly the objective data that the omics and other lifestyle factors provide for us. So with that, I'll stop and let the other panelists have their opportunity, but thank you again for this time to present to you.
Hi, everyone, and it's really a pleasure to be here. I'm Corby Martin, and I'm one of the panelists. I'm very happy to chat with you for the next 5 minutes. If we can bring up my slides, that would be fantastic. Great, thank you. So first and foremost, the presentations today were exceptional and excellent. I think that the field is getting to a point where we are now conducting research that ascertains causality, such that we know that a certain dietary intervention is having a specific effect on a health outcome. And most importantly for the discussion today and tomorrow is that we are now detecting these interactions where we can see that a dietary intervention or a certain dietary pattern has a certain effect on a health outcome in one population and not the other, or via some other third variable. So this is all really promising. And I think that given the focus of the NIH over the next 5 or 10 years, we can conclude that further research in this area will occur. And this is good because we currently have a number of available tools that we're hearing about today and tomorrow that allow us to conduct really detailed research on interventions, on dietary interactions with things like the microbiome, chronobiology, meal timing, as well as other factors such as race. So this is good and bad. I think the opportunities there are quite obvious, but I think some of the risks are that we will pursue research within our own fields and do really important research to answer important questions for our own field. We'll publish within our fields, and that's all fine and good. But I think that we really have to aim for conducting multidisciplinary research to answer these very specific questions, but also extrapolate them to the broader context and really try to impact the health of Americans through implementation research and other types of research. So this really leads me to what I would like to list as important fundamental challenges in conducting nutrition research and also addressing some important research gaps. And the first thing that I'll mention is that I think we have to really mind the energy balance equation and disentangle the effects of energy balance from dietary intake or dietary patterns. So we know that, say, for example, restricting energy intake has profound effects on many health outcomes, and the influence of restricting intake on different diets, there's some limited research there, but we know that it's a little bit unclear. But I do think we really have to really differentiate these two or consider energy balance when we're conducting dietary pattern research. Secondly, I think this is really what Linda and others referred to today, is that honestly, we have to ask ourselves the question, do we really know what people eat over the long term in free living conditions? I've dedicated a lot of my career to trying to answer that question. And you all know it's extremely challenging to accurately quantify what people eat over the long term with enough precision to actually pick apart these relationships and interactions, and further to determine whether or not people are indeed following the precision nutrition plan that we set out for them. Without that data, we are really in tough shape, and I'm not convinced that we as a field are going to answer this question sufficiently. That is, I'm not convinced that we're going to continue to develop methods that can precisely and accurately enough quantify what people eat over the long term. And lastly, I want to close my discussion by referencing the two questions from the audience about the challenges of having Americans follow even rudimentary dietary guidelines, and also the challenges that many Americans face because they have limited access to healthy food. So I'll just say quite succinctly that in my view, many Americans have what I will call limited choice in their dietary patterns due to physical access, food insecurity, affordability, cultural issues, seasonality, and you name it. And this is a problem. And I think it has big implications for our ability to implement and roll out precision nutrition initiatives. And I'd take a step even further back at a much broader picture and ask whether or not our food systems are adversely affecting our dietary patterns, and if we should also be investing more resources to manipulate or modify the food supply to make it overall healthier, if we can agree on what that might be, but also to provide access to the variety of foods that the U.S. population will need if we truly intend to have different people or different groups of people following different types of diets, whether it be Mediterranean, low fat, low carb, or what have you. So I think that that's a big question for me, and I very much am concerned about really rolling these findings out and impacting the health of Americans. And lastly, I want to conclude with the fact that we have to remember that eating is a behavior, and we have a long history of really underperforming at helping people follow our dietary interventions. So adherence can really struggle or become poor after a couple of weeks or months. And so I think we obviously need to dedicate resources to try to find ways to better intervene or better foster adherence to these precision nutrition interventions. And I'll close there. Thank you so much.
Okay, thank you. Do we have Steve Clinton?
Jose, can you hear me on the phone?
Yes, we can. Go ahead, please.
Well, I could speak if someone could put my slides up.
Okay. Go ahead.
Can you see my slides?
We can see your first slide, precision nutrition, Steve Clinton, the James. So your presentation, yes.
Okay, well, thank you. I'm sorry we're having some interesting technical difficulties this morning in getting the appropriate link, but let me just make a couple comments. And I think this first slide just sort of gives an overview of my thought process on this, looking at the public health model and then what I call the medical model. And as you've heard all morning, I mean, we have this one-size-fits-all when we talk about dietary guidelines for America or the World Cancer Research Fund's guidelines for cancer. And these are population focused. And you just heard some caveats and some challenges that we have, making sure that we have food systems that really are dependent upon state, local, federal regulations, the FDA, the USDA, working with corporations to ensure that all Americans, regardless of social and economic background, have access to healthy, quality foods, and of course, a built environment that allows the appropriate amount of physical activity. This is a big challenge. And even when an individual wants to follow some of these guidelines, there are enormous obstacles. And I think in the medical model, as a physician, I'm very attuned to issues of compliance and in the medicines that we provide. And one of our biggest challenges in the medical model for food and nutrition actually gets down to the healthcare system and the insurance that we have for people and the ability to have appropriate nutrition counseling with the registered dietitians that is reimbursed and that it has the intensity and continued duration that we need in order to have impact. And so we can do the science, we can define the goals and the guidelines in precision medicine that are unique for each person, but we still have to implement these, and we have to have a healthcare system that truly is going to support preventive care. We do need both. Now, the next slide, to me, I use this to give an overview of how I think about the precision nutrition in the cancer continuum. And indeed, a key point in many people's life is the diagnosis of cancer. And we've done a great deal with epidemiology, observational, and even some intervention studies on the prevention space. And the World Cancer Research Fund, AICR, have done just enormous work, along with the World Health Organization and others, to take the data we have, and we can come up with good, one-size-fit-all public health guidelines for cancer prevention. But the future in the prevention space is actually to take folks that have individual needs, whether that's due to the presence of family history, known genetic abnormalities, the presence of premalignant lesions, and specific types of exposure, such as tobacco. And how do we refine our guidelines so they're more precise to approach prevention for these individuals? When we move into cancer therapy, our diet, nutrition, and cancer research is woefully behind. Therapeutics for cancer are increasingly successful, but increasingly complex. We integrate surgery, chemotherapy, radiation, hormones, immunological therapy, and biological therapy, often in complicated combinations. We really need to do the research to integrate nutritional assessment and monitoring within phase 2 and phase 3 clinical trials, so that in the end, we have the data that allows us to do randomized controlled trials and ultimately enhance the efficacy of our therapy, enhance the safety while reducing toxicity. Once our treatment is done, we move into a survivorship space. And here we have another tremendous opportunity for precision medical care. We certainly want to reduce the risk of recurrence, developing second primaries, or developing second malignancies, sometimes due to the therapeutic agents that we provide. Long-term organ toxicity, now that the survivorship population is increasing, is appreciated much more. And how do we provide the dietary guidance to limit long-term complications, cardiovascular, renal, cognitive, in the survivorship space? And many of these things are going to integrate genetics as well as the unique features of each person's treatment. And we also want to emphasize the quality of life and survivorship issues. And finally, I'll just sort of say that what we really need in this space is we really have to support the research, and we need to make sure that therapeutic trials particularly integrate food and nutrition as part of the standard approach. You wouldn't do a therapeutic trial without the common NIH toxicity tools that we use for everyone, and I'm not sure why we're not integrating food and nutrition into that space as well. We will continue to need data from observational trials, but more importantly, we need well-designed, well-thought-out, randomized controlled trials in this space. So I'm hoping that this new initiative will lead to increased efforts to enhance our evidence-based medicine and improve the precision of our care. Thank you.
Good morning. I'm Meydani, and it's a pleasure to be here today. I have certainly enjoyed the excellent presentation. I was asked to highlight the interaction between nutrition and immune and inflammatory responses and risk for diseases. Given I have to do it in 5 minutes, please bear with me as I oversimplify some of the concepts. A key role of the immune system, at least as we traditionally understood it, is to defend against pathogens and tumors. How well the immune system does this will determine if we can get rid of the viral or bacterial infection effectively, as well as the long-term effects that such a response by immune response will have in terms of development of chronic diseases. Both the cell-mediated and inflammatory responses are needed to get rid of an invader. Under normal conditions, when cell-mediated immune response is working well, once the invader is neutralized, the inflammatory responses will dissipate and go back to pre-invasion level, and all would be well. If, however, you have hyperreactivity of cell-mediated immune response, you would be at higher risk for several diseases, including some of the ones that are listed in this slide: infection, autoimmune disease, cancer, arthritis. On the other hand, if you have uncontrolled inflammatory responses or hyperreactivity of inflammatory response, chronic inflammation will develop, which increases the risk for chronic diseases, including the ones that we discussed today earlier. Many factors can influence the development of optimal immune and inflammatory responses. Key factors are nutrition and aging. Both under and overnutrition or obesity can impair cell-mediated immune response and produce chronic inflammation, which will increase the risk for infection and several of chronic diseases. Similarly, with aging, there is decrease in cell-mediated immune response and increase in inflammation, which is often referred to as inflammaging. We know that there is great heterogeneity in immune and inflammatory responses among individuals and within an individual, depending on environmental, genetic factors, seasonal changes, and time of the day. So, given the important role that the immune and inflammatory responses play in risk for diseases and the level of heterogeneity in immune and inflammatory responses, understanding the relationship between nutrition immune and inflammatory responses in relation to chronic and infectious diseases needs to be a key component of developing personalized nutrition research and recommendations. Immune and inflammatory responses actually provide a great opportunity for personalized nutrition research because the immune system is easily accessible and could be studied for the most part with non-invasive methods, and with the many advances made in recent years, we have a very good understanding of how it works. There is, however, a big gap when it comes to research related to influence of nutrition on immune and inflammatory responses, which I hope this initiative will be able to address and advance so that we would be able to have a better understanding of how nutrition will influence immune and inflammatory responses, and as a result, the risk for both the infectious and chronic diseases. Thank you so much.
Well, thank you. Thank you, Simin. Thank you, all the previous panelists. And if we can bring back all the panelists and the speakers will be great, because now is the time to share ideas. One of the objectives of the meeting, of the workshop, is obviously to identify the gaps. Some of them have been identified already in your talks, but as a speaker, you were limited to 15 minutes, and probably you left many things that you wanted to say out of your presentation, and the same applies to the panelists. So I think now is the time to go over those things, to identify those gaps and opportunities that we have ahead of us in terms of precision nutrition. I don't know if anybody can volunteer to start the interaction. Mary,
I can. Yes.
Okay, Mary, go ahead.
Yeah. So someone during the conference asked me a question of how, in my research, we're able to ferret out to what extent reductions in glycemic exposure are due to changes in carbs and glycemic index versus personalization. And I think this was a really good question. And, you know, in order to do this, just so that you know, we're collecting dietary recalls, and we can examine, you know, between group differences in macronutrient intake in that way to some extent. But I think that that it raises a really good point in terms of, you know, looking at measurement of dietary intake, and, you know, dietary decisions are made in real time, and, you know, making sure that, you know, we're adequately capturing the variability in dietary intake, and, you know, assuring to some extent that people are actually adhering to the protocol are really going to be necessary components of really being able to get to, at the end of the day, being able to say that this is in fact an intervention that clearly works. And, you know, I wonder, you know, if anyone has any suggestions or comments or observations about, you know, current mobile applications that are being used, or other alternative measurement approaches for, you know, being able to assess via biomarkers. I mean, this is not my area of expertise, so I just wanted to throw that out there to the group.
Anybody wants to take the baton?
I can comment not on the bio. Oh, go ahead, Linda.
That's okay.
Linda, go ahead.
No, go ahead. All I wanted to mention is I think that there are definitely studies moving forward with mHealth mobile applications to this question. I think that the data thus far are still relatively crude, just in terms of what can be accomplished on someone's phone. I'm also aware that in certain populations, especially those that have lower literacy or lower access to specific applications on a phone, just taking a photograph of what's being consumed has also been approached as one additional method of being able to document what's being consumed. obviously without the precision or the detail that we would prefer in a 24-hour recall. But it is illustrating, I think, movement towards trying to combine convenience for the participant and lower the burden for the participant with accuracy in terms of being able to document what's consumed. It's a moving target at this point.
Yep.
Can I?
I don't know if Martin, Corby, do you want to?
Yeah, I'll just elaborate real quick because it's directly related to Linda's comment. Yeah, so this is a big problem, as I mentioned in my discussion, and I think there are now tools available that rely on food photography, where the user captures images of their food intake with smartphone apps to very accurately quantify food intake, but only over the short term. So the problems with that approach are that it's only over the short term. People won't do it 24 hours a day for, say, 2 or 3 months. It's simply too burdensome. And the second problem is that to get the precision and accuracy that we want, it takes time to analyze the images. And our work and other people's work demonstrates that when you integrate, say, machine learning and things like that into trying to automatically identify foods in the image, link them to a nutrient database, and estimate portion size with computer simulations, it's extremely challenging. The data is not good. And I'll say that just globally, right? Like the efficiencies aren't there yet, and the accuracy as compared to a human rater is simply not there at the time, but hopefully it will be here in the years to come. So I think that's a major challenge. Now with the biomarkers, I think there's a lot of promise there, but I think we have the same challenges. Getting the data back in time for it to be clinically relevant, and clinically relevant for the clinician and also for the participant or the patient, and also precision. We need really precise measures to allow people to follow these precision nutrition interventions like we want, and I'm not sure it's going to be there.
I guess one of the things that my observations is that people have a tendency to eat from a fairly limited repertoire of behaviors. Like I eat the same thing for breakfast every day, and I eat maybe 1 of 3 or 4 different lunches. And most of my variability occurs at dinner time. And I just wonder if there are ways to we think in terms of, oh my heavens, I have to know exactly what this person is eating and every single food for every single meal for the rest of their life. And, I would suggest that we might be able to use precision nutrition to identify specific patterns of behavior that might be predisposing people to, adverse outcomes, and then making more generalized recommendations that are personalized to them.
Simin?
Yeah, so I just wanted to add that it's obviously great to have the dietary intake data, but particularly for assessment of the micronutrients, that might not really be as accurate as we would like them. So incorporating more sort of biological measurement of the micronutrient status will be very important if we are to have accurate information about status of the many of the important micronutrients that are contributing to the risk for the chronic diseases. So I'm hoping that this would be incorporated as part of the overall assessment of the diet. I know it's harder to do, but it's something that I think could contribute to a lot of the controversies or a mismatch of the data that we get in terms of the relationship between the micronutrients and diseases.
Thank you, Simin. Anybody wants to contribute with any more thoughts? Okay. We have, obviously, we have a problem with the measurements of what we eat, but part of that precision nutrition is to identify that variability that is among individuals in terms of when we eat the same thing, right? The inter-individual variability. But it's interesting, we were talking about glycemic index. There is work from the lab of Alice Lichtenstein at the HNRC that shows that, for example, in terms of measuring glycemic index of bread, there is more intra-individual variability than inter-individual variability. And this could be, you know, just a single occurrence, but then later, Ronald Mensik in the Netherlands reproduced exactly the same effect. So considering how much we rely on glucose metabolism or glycemic index in terms of the recommendations, how do we can address that additional complexity of the intra-individual variability, the fact that the same individual responds differently in different days?
Well, Jose, I think the implication of that is that certain individuals then shouldn't consume that type of bread, and so they need an alternative substitute that is healthier for them. And so I think identifying that and then making it available and affordable is going to be critical. So I think, I think it's really important research, but we have to think about what is the practical implication for the patient. And that's where things can get really, really challenging.
Okay. All right. Any other comment? Then,
well, and I think, sorry.
Go ahead, please.
Just to add, Jose, one other point about this is I don't think this is confined only to glucose metabolism. We have seen similar data, for example, in sodium and hypertension. And we all recognize the tremendous variability in regard to dietary sodium intake and the differences across processed foods, et cetera, which my only comment, as I was addressing earlier, is one of the global features that I think could be addressed overall. The processing of food that has occurred and has increased tremendously over the last 2 decades in this country has clearly had a major influence in terms of detrimental impact on a whole host of different metabolites and other microbiome-related features. So I think, something as broad as processing of food and what needs to be done to try to enhance the overall nutrient density of our food supply or return to what previously offered nutrients that are now being obliterated. I think that represents something we could probably all agree upon as far as being an improvement more broadly in this country.
Thank you so much, Linda. Well, we have 1 minute left. Maybe very quickly, as we have to identify gaps and opportunities. Each one of you can say in one word, what is the major gap that you see and what is the major opportunity? We can start in the order that we have in the screen. Corby?
Oh boy, I'm put on the spot. I think our major gap is that, in my perception, is that we need to be conducting more multidisciplinary research to answer these really important questions from the bench to the bedside to the community. And I think that's a major opportunity. I think if we can focus on those areas, we'll make a lot of progress.
Thank you. I think that's something that we'll be dealing with tomorrow. Simin, you are next.
Sure. I mean, I sort of already alluded to that, but I do think that we are missing an opportunity to focus in terms of personalized nutrition on the interaction between nutrition and immune response, because obviously it is playing such an important role, not just for resistant to infectious diseases, but in all of the chronic diseases that we know so far. And I think it does provide a great opportunity for us to learn more about how to make personalized recommendations based on research that is could be performed in humans.
Thank you so much. Emily, you are next.
Yeah, I think overall there just really needs to be a bit of a culture shift in terms of how we think about doing our science and how that applies to what we're going to be recommending in the clinic and in the population as well. And it is going to take, as Dr. Martin suggested, an integrative approach and really to think ahead in terms of who's making the recommendations, who's going to apply those recommendations, and what are the systems to be able to use these AI and data sources to inform. And if we don't have that base infrastructure, you're going to have holes as you move forward.
Linda.
Right, and I agree with everything that everyone has just said. However, I would also add, speaking clinically, of EDW, collecting dietary assessment data in a standardized manner so that we can use electronic data documentation that all of us have access to that could help us in terms of precision nutrition for the patient.
Wonderful. And Richard, you are next.
Great. So you asked for a one-word response, but I'm going to use a hyphenated word, and that is buy-in. I think we need buy-in from clinical folks like me who may not have had the type of nutrition education that I wish I had in medical school. I love my medical training. I'm super appreciative and worked very, very hard, but I think there just needs to be buy-in from clinicians and think about nutrition as a personalized and precision nutrition as a real thing that has real science and is our future in clinical care.
Wonderful. Mary?
I think getting people to change behavior. We can have the most elegant science, and if we can't get people to change behavior, it's all for naught.
I don't see if we still have Stephen on the phone. Well, probably no. In that case, well, we need to end the discussion at this point. Thanks to all the speakers and panelists. And the audience.
Stephen is here.
Ah, Stephen is there. Well, okay, then I will save the thanks for later. Go ahead, Stephen.
Yes, I would just use the word intervention. We need intervention trials, evidence-based. Okay,
that was one word. Wonderful. And you don't see Richard, but he says yes. See, very good. Okay, so yes, now really we need to end the discussion. And again, thanks to all the speakers and panelists and the audience for the contributions. Sorry for the potential technical difficulties that we had here in the backstage. We cannot see what is happening in the front of the auditorium. But somebody asked whether it will be possible to have the presentations. Well, you will be able to have the whole thing that you can review and you can see, because that will stay available for, I think, at least 1 or 2 years, right? So yes, you will be able to revisit, and people that were not able to register, they will be able to have access also. So now remember that you have a few minutes to run to the poster hall and interact with the poster presenters. And after the break, we'll hear from Holly Nicastro about the Planning for Precision Nutrition Health, powered by All of Us program. Again, thank you so much, and I will be seeing you soon.